So today we'll start talking about aneurysms. There's nothing, I think, that strikes fear into patients than that diagnosis, aortic aneurysm. For obvious reasons, it's a potentially fatal problem, but in reality, most people who have aneurysms don't need anything done about it. It's just that the stories you hear, the ruptured aneurysm, people passing, wealthy people, rich people. Albert Einstein died of a ruptured aortic aneurysm. John Ritter died of aortic dissection, which is a different topic, which we'll discuss at a later date. I think Lucille Ball died from ruptured aortic aneurysm. Conway Twitty, I think, died from a ruptured aortic aneurysm. Don't fact check me on that one because I don't know country music very well. But so anyway, you hear these stories about people passing from ruptured aneurysm, and it scares people. Obviously, it's a scary topic. So there's different aneurysms at different sites, and they have different natural histories. So what is an aneurysm? An aneurysm is an enlarged blood vessel. Just kind of a generic definition. It's an enlarged blood vessel. So, there's a normal vessel, there's arteriomegaly or enlarged blood vessel, and there's aneurysmal. So it's kind of a continuum. But generally speaking, an aneurysm is by definition 1.5 to 2 times its normal size, normal vessel size. So you have an aorta that's maybe 2 centimeters in size in a male, and if it gets to 4 centimeters, that's an aneurysm. So that's the kind of definitional thing. There's also true aneurysms and false aneurysms, which we'll talk about later and get into more depth. But a true aneurysm essentially means all the enlarged area is the vessel wall, and then the pseudoaneurysm is really kind of not the same thing. So an aorta or an artery has 3 layers to it: the intima, which is the inside portion; the media, which is the middle portion; the adventitia is the outside portion. So intima, media, adventitia, and in a true aneurysm, all those 3 layers are bulging out. In a pseudoaneurysm, they're not. So incidentally, I always ask the surgery residents these questions, what's the strongest layer of an arterial wall? And it's actually the adventitia, the outermost layer. When we do carotid surgery, we take out the plaque in the carotid surgery, which we'll get to at a later date. We take out the intima, media, and part of the adventitia, and the adventitia is what's the strongest component of the blood vessel or the artery. So anyway, an aorta is an enlarged blood vessel. Why do people get aortic aneurysms? Well, there's several risk factors for it. Men get it more than women, particularly men who smoked. In fact, so much so that any male who smoked over 100 cigarettes over age 60 needs a screening for an aortic aneurysm, according to CMS or Medicare. So there's a Welcome to Medicare screening for males who are over 60 who have a history of smoking over 100 cigarettes in their lifetime. It's recommended that they get a screening ultrasound to evaluate for aortic aneurysms or enlarged blood vessels. So certainly males who smoked in the past can run in families. If mom and dad had one, you're at risk for getting them. So that's another risk factor. And then each decade you go up in life, you have a higher risk for getting one. If I screened or did a CT or ultrasound on 100 people in the 70s, I'd probably find 3 or 4 of these aortic aneurysms, which people didn't know about. In fact, that's probably the most common way we find aortic aneurysms. You have a test for another reason. You have kidney stones, you have an ultrasound or a CT scan, an incidental finding of an aortic aneurysm. So that's how most of these things are found. Now, physical examination, you can feel them, especially if you're kind of like in tune with this stuff. So the aorta comes out of the heart, it gives off the branches, and it comes down underneath the diaphragm, and gives off the intestinal arteries and the kidney arteries. Well, it's slightly to the left of the spine, on the spine. So it's slightly to the left of the midline, slightly on the spine. If you're heavy set, it's hard to feel it. But if you're thin, then you can feel it. The pulsatility on physical examination, you can feel the aortic aneurysm. There was a study, I think, at the VA in Minneapolis where they looked at people with known aortic aneurysms, if I remember right, and essentially 50% of the time people were incorrect about whether the patient had an aneurysm or not. So, physical examination in really good hands, yeah, and if you're thin, you can feel them, but my way of evaluating this, if I feel on physical examination the patient might have an aortic aneurysm, I schedule an screening ultrasound to make sure, because it is important to detect these things. So most of them are detected incidentally when you have another test for another reason, and then we decide how to manage it. So there's really no great medical management of aortic aneurysms. Think of it this way, it's a ballooning out of that artery. So what happens if it gets too big, it's going to tear open, and that's where you get all these fatal events that scares people, okay? But the natural history of most aortic aneurysms is they do not tend to get bigger with time. They do not tend to get bigger and need surgery. So most of them can be monitored. So let's say, for example, you get diagnosed with an aortic aneurysm. What's the issue with it? What needs to be known? Well, you need to know where it is in the aorta. The aorta goes from the chest all the way down to the legs. It splits about the level of the belly button to supply your legs. And so where is this aneurysm? Most of them are below the kidney arteries, so what they call infrarenal. So most of them below the kidney arteries. Sometimes they extend into the leg arteries. So kind of irrelevant. So the size is the important part. How big is this thing? So we use it ultrasound screening or CT scan if you've got you're having a CT scan for another reason. How big is that aneurysm? How wide is it? Not so much the length, although that is important. That's the width. So in men, 5.5 is the magic number. 5.5 centimeters, which is about yay size. So that's when we start worrying about it. Women, it's 5 centimeters. And so those are the magic numbers. So a man with a 5.5 centimeter aneurysm, we worry about more. A woman with a 5 centimeter aneurysm, we worry about more. Not that we don't worry about anybody who's had aneurysms, but those are the cutoff points for fixing stuff. Now, having said that, that's not the only criteria for fixing these things. Like say for example, you come to the office and you have, you're a 70-year-old gentleman and you are diagnosed with an aortic aneurysm 4 centimeters in size. Well, do you need that fixed? No, you don't need that fixed. You just need to be monitored with regular ultrasound testing in the office, and there's guidelines for all this stuff. But let's say, for example, you come back in 6 months, let's say, and you have an ultrasound of your abdomen and your aneurysm's up to 4.5 centimeters. Well, that's considered a significant change. A 0.5 centimeter change in the size of an aneurysm over 6 months or 1 centimeter over years follow-up is considered significant. So in that situation, you may need to consider surgical treatment for this stuff. But like I said, I'm estimating maybe 1 out of 10 people that I follow for aneurysm disease progresses to the point where they need surgery. Most people don't progress to the point where you need surgery. So how do you prevent it getting bigger with time? Well, it would logically make sense that your blood pressure is well controlled. You think of this as like a balloon. If you got a balloon, you want to control the pressure into the balloon to try and prevent it getting bigger. If you physics nerds, that's Laplace's law. If the radius of the circle, the balloon gets bigger, then the pressure and the tension on the wall is bigger, and so you get bigger and it tears open. Unfortunately, it doesn't always follow. So people have excellent blood pressure control, whose aneurysm gets bigger, and people who have poor blood pressure control, aneurysm stays the same. So I wish I could tell you that makes a huge difference. Although it makes sense to have good blood pressure control for other cardiovascular reasons, right? Strokes, heart problems, and all that stuff. So the key is just regular surveillance ultrasounds. So I check people regularly, and then if the aneurysm is getting bigger, then I proceed to a CT scan I only proceed to a CT scan if I'm considering recommending a surgical intervention. So surgical interventions, again, in men, 5.5 centimeters, women, 5 centimeters, or if it's expanding with time, 0.5 centimeters in 6 months or 1 centimeter over a year's period of time. Then I schedule CT scan, consider surgical repair. CT gives me measurements for the aneurysm. It's a better test in terms of size, and it gives me dimensions and where, what they call landing zones and how much room I have to do these things. And so the CT is a planning tool for intervention if needed. So why don't we just do CTs on everybody? Because there's radiation to CT scans. Ultrasound has no radiation. CT has radiation, so if you can avoid the radiation, great. So I follow people regularly with ultrasound. If it's getting bigger, then I consider a CT scan, depending on the size it started off at, obviously. So anyway, this, blood pressure control makes sense, and risk factor modification for cardiovascular disease. Smoking cessation, blood pressure, cholesterol, blood sugar control, regular physical activity. People ask me, well, can I exercise? Yeah, I think you can exercise. I don't have any problems with you walking regularly. Is it good to lift heavy weights? I'm not sure of any great data to that. What I suggest to patients when my patients are elderly, particularly, is why do you want to lift something heavy? You don't want to hurt your back more than anything else. Yeah, so I just say, just do your normal activity, walk, whatever, and maybe stay away from anything super heavy weight-wise, maybe 40 pounds or less. I'm comfortable with people doing that kind of stuff. But, most patients that I follow don't get bigger and need fixing, but I always tell them these few things, okay? What are the signs and symptoms of an aneurysm getting bigger? It's the worst belly or back pain you'll ever feel, and it will not go away. So if you have a 4.5 centimeter aneurysm and we're planning to be conservative and not fix it, I'll see you, let's say 6 months with ultrasound. However, if you start having belly or back pain out of proportion to your normal mild back pain that doesn't make sense, I need to hear from you. I need to see you and examine you, because if I examine you and that aorta I feel is tender, then I'm worried more about this thing getting bigger. Or if the nature of your nature of your back problems has changed, your back pain has changed, then I'm more worried. Then I'm going to look into it a little bit more, maybe get a CT scan and take a look at it and see what the measurements are. Again, because the CT gives a more precise measurement of this aneurysm. So new onset back or belly pain doesn't go away. It's not like, I hurt my back and it's a little stiff and tight, but I'm okay tomorrow. Pain's gone away. That's not aneurysm. It's worsening back or belly pain, and then we need to be evaluated. So in terms of management of most aneurysms, they can be managed by regular surveillance in the office with ultrasound testing. And most people, like I said, never get to the point where they need fixing. If you get to the point where you need fixing, there's a lot nicer ways of fixing these things than what I used to do 30 years ago to people. I mean, a lot nicer way. 30 years ago, we didn't have all these technological options. So we would make a big belly incision and essentially replace that aorta, that aneurysmal segment, with a piece of tubing. It was, sewing it in, replacing that segment. Tough operation to get through. You were in the hospital about 5-6 days. You were stiff and sore for about 6 weeks. Had diarrhea, constipation, nausea, lose weight, just don't feel great. I eventually went back to normal, and some people really should have an open surgical repair because they do better in the long run. But the aneurysm repair using endovascular technique is a lot nicer on you. It may not be the optimal choice for you, depending on your, other issues, the anatomical measurements and all that stuff. But generally speaking, the aneurysm repair with endovascular stent grafts is a lot easier. And I'll kind of show you a model of that at a later date when we talk about endovascular repair and an open surgical repair. So in terms of management, if this thing doesn't get bigger, we just monitor you regularly in the office. If it gets bigger, we talk about the surgical repair. In terms of surveillance for aneurysms, that's another topic. So like screening for ultrasound. You see all this screening. People screening for carotid artery disease. You get these flyers in the mail, screening for aneurysms, screening for carotid artery disease. I'm not so sure the benefits of that stuff. I think if you have a family history, you're a male, you smoke, you're over 60, fair enough. That's fair enough for the screening for an aneurysm. My concern is this. There was a recent publication, Society of Vascular Surgery, and there may be a good explanation for it. But when they looked at patients from Medicare data, I believe, they looked at Medicare patients who had aortic aneurysm repairs. 13% of those repairs did not have in the chart or in the paperwork an indication for the repair, i.e. meeting the criteria for repair. So that's very concerning to me. Even though the minimally invasive endovascular repair is tolerated, there's some potential risks for it or from the surgery itself. And so to see 13% of aneurysm repairs not indicated per the charts is concerning to me. That doesn't mean that there was no good indications. It just wasn't documented very well. But it's still kind of concerned to me. And it kind of goes along with the theme, in my mind, of vascular disease in terms of intervention is over-treated. You know my feelings about peripheral vascular disease and how I think claudication or tightening of the calf muscles when you walk, that's far too aggressively treated. And so the screening for an aneurysm makes me worried that there's going to be more and more of these treatments that are done that are or may not be indicated. And so I'm not sure what to say about screening stuff. It kind of worries me a little bit. Next time we'll really kind of get into aneurysm repair, the open technical repair versus the endovascular stent graft repair. I'll show you some models of what that involves and what the potential complications of it are. And then once we get over the aortic aneurysm discussion, then we'll go to other aneurysms, because there's other sites you can get aneurysms, behind your knees, in your leg arteries. Brain aneurysms are a different entity than these other aneurysms that we're talking about. You can get them in your spleen arteries, you can get them in your kidney arteries and different things like that. So we'll kind of get into the other sites at a later date. But I think next time we'll talk about aneurysm repair, the open surgical repair versus the endovascular repair.